Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et est disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated.
We get started. Bonjour, bienvenue. Hello and welcome everyone to March Grand Rounds, Family Medicine Grand Rounds, and happy spring, I think. And we're very fortunate today to have two presentations, three speakers. And I'm going to introduce all three speakers right now, and then we'll begin. So our first presentation will be by Dr. Agnes Grudniewicz, who's an associate professor at the Telfer School of Management here at the University of Ottawa. She's a health services researcher focused on primary and community care. Using qualitative and mixed methods research, she explores team-based primary care and collaboration across settings and care providers. Her work aims to inform policy and improve Canadian healthcare systems. Dr. Grudniewicz leads the Cross-Provincial Health Systems Research Lab. Our next presentation will be by Dr. Sathya Karunananthan, who holds a PhD in epidemiology from McGill. She's an associate professor in the Interdisciplinary School of Health Sciences here at U of O, and an investigator at the Institut de Savoir and also Briere Health Research Institute. She holds the Academic Health Network University Research Chair in Language as a social determinant of health. Sathya's research on health services focuses on improving access to care for older adults with complex health conditions such as dementia. She investigates disparities in care access among underserviced communities, specifically linguistic minority and racialized groups. She studies the impact of health technologies like electronic consultation and artificial intelligence on inequities in access to care and health outcomes. She'll be joined by Dr. Claire Godard-Sebillotte, who's a geriatrician at the McGill University Health Center, assistant professor in the Department of Medicine, Division of Geriatrics at McGill, and a researcher with the McGill University Healthcare Research Institute. She studies equity in care for people with dementia using participatory and intersectional approaches. In order to produce evidence for decision makers, she uses mixed methods, combining analyses of health administrative databases, advanced statistical methods to infer causality from observational data, and qualitative methods such as interviews and deliberate dialogues. So with that introduction, I'm going to hand things over to Agnes.
Fantastic, thank you. Great, so thank you very much for having me. This is my second time presenting at these rounds, but the first time was a really long time ago when it was in person at Briere, probably in like 2017 or 2018. So I'm really excited to be back. Today I'm presenting a presentation titled Supporting Primary Care, Insights into Clinic Management and Administration. And I'm looking forward to sharing some of what we've done, but also hearing your thoughts on this work as well. In terms of conflict of interest, I do need to disclose that I hold research funding from Shoppers for an unrelated study regarding point of care testing and have no other conflicts to declare. And of course, very important that we start with Indigenous affirmation. And today I'm using the Indigenous affirmation from the University of Ottawa. We pay respect to the Algonquin people, who are the traditional guardians of this land. We acknowledge their longstanding relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. And I'd like to also acknowledge research funding for this work that comes from CIHR, SSHRC, or Social Sciences and Humanities Research Council of Canada, and Research Nova Scotia, as well as acknowledge that this work is not mine alone in any way, shape, or form. It is a result of collaboration and work within the Health Systems Research Lab, which I am a co-lead of, along with Dr. Lindsay Hedden, David Rudaller, and Ruth Laverne. And none of this would happen without our amazing staff, Rachel Tellin, Ellen Randall, and Sarah Spencer. So the problem that I'm addressing today is one everyone is very familiar with, but I do want to say a few quick words just to position what we're talking about. So we know that family medicine residency spots are left unfilled, that recent family medicine graduates are really reluctant to open new clinics, that family physicians are feeling overworked and burnt out, and that family physicians are leaving practice. And so all of this is leading to what I believe is that traditional, longitudinal, comprehensive primary care, or whatever you want to call it, our usual like in-clinic primary care, is at risk. However, it's not dire because we have a beautiful window of opportunity. Everyone is paying attention to primary care. When I was here last, primary care wasn't such a sexy topic. And right now it is something that people, when they hear that I do research on primary care, are really interested and excited in a way that's never happened before. More importantly, it's being prioritized by all three levels of government, including federal, provincial, and municipal governments, which is quite, I think, unique and rare. And that's resulting in tangible investments and primary care reform. But with the focus on attachment in Ontario, on physician payment reform, and on increasing team-based care, it leaves us to ask, are we using the right solutions and will it be enough? And so my presentation here is to talk to you about a different thing that's not getting enough attention. So I'm presenting one stream or one program of research from our Health Systems Research Lab. And within that, I'm going to talk to you about the paper cut study in primary care, which is completed, and the PracMan study, which is just underway. And along the way, I'll share with you a bonus project because we have this problem on our team where we get funding to do one thing. The funding is obviously cut by like 23% across the board, if not more, usually more. And then we're like, okay, we don't have enough money to do everything we want to do, but like, let's just add this other fun thing that we want to study and use like spare change to fund it. So I'll share one of those fun projects. So the paper cut study was led by Dr. Ruth Laverne, looking at the problem of the growing administrative workload, which won't be a topic that's new to anyone here, I'm sure. And the fact that administrative burden has been associated most of the time in the literature with unnecessary administrative tasks. However, this doesn't recognize that necessary administrative tasks, such as continuity and coordination of patient care, is also important and contributes to administrative burden. And the fact that this work is often completed by women, it's often invisible, not valued or recognized. And so we felt that there was very little research conducted on experiences and solutions of administrative workload overall. And if you're interested in learning more about the study, I don't have a lot of references here because things are still in publication. You can head to our website, which is healthsystemsresearch.ca, and you can click on our current work and it will be there if you'd like to read our protocol or the report. So this project looked to determine how the volume of services requiring primary care coordination has changed over time in Canada. And that was a quantitative analysis of EMR data of lab tests, referrals, and prescriptions to understand experiences of administrative workload among not just clinical staff, not just clinicians, but also administrative staff in Nova Scotia and New Brunswick. And that was done through 36 qualitative interviews. And lastly, to co-identify priority issues and co-develop practical solutions to make primary care administrative work more efficient specifically in Nova Scotia. And so that was 4 qualitative expert conversations with 21 participants. So what we found, the Canadian EMR data suggests that across the country, administrative workload really has grown between 2011 and 2021. And that was the case when we looked at the individual physician level, at days worked, patient and patient visit levels, and when controlling for physician characteristics such as age or gender. For example, lab tests increased 57% in that time, and referrals increased 29%. We also found a differentiation in how people spoke about administrative work and administrative burden, and felt that it's important to differentiate this in the literature and our definitions going forward, with administrative work being activities that are required for the operation of primary care, including indirect patient care, and running the practice of the clinic, running a practice or clinic. And administrative burden was really the experience of administrative work as a source of stress or difficulty or hardship or worry. One of the main sources of administrative work was information management. And here we found that it's not just one simple experience, but it really involves the stewardship of information, clinical responsibility over interpretation of information, and a moral responsibility to the patient about their information. And not surprisingly, in our expert conversations, we didn't find one single strategy to address administrative workload or burden. It's very multifaceted. Oh, my picture migrated. Sorry about that. So the recommendations that we found, I think, are not surprising and are fairly on point. We found through our conversations that technology isn't sufficiently tailored to the primary care context, which creates a lot of pressures for administrative staff and clinicians. The complexity and lack of streamlining of information exchange across external systems was also a point of tension. And for me, most interesting was a need to support administrative staff. So administrative staff really requested additional training for the primary care context. They're looking for tailored policies and procedures to the specific clinic, not just to primary care. Much more investment in the right tools to do the job. And overall, we found a really strong need for improved retention, with a lot of clinicians speaking to difficulty in retaining staff over time. So this leads us to the bonus project. So we're really interested in what are the competencies and responsibilities in primary care administration. So we pulled together this team of students. So my master's student is really leading this work for us right now, along with some colleagues at Dalhousie University and some additional students and staff as well. And here we wanted to know, what are the roles and responsibilities for non-clinical administrative roles in primary care in Canada? And what are the required competencies, training, and work experience of non-clinical administrative roles as well? And we're curious how these vary across provinces and territories. So we decided to do a review of the Canadian job advertisements in primary care administration. So we asked some of our colleagues who run primary care clinics where they post their jobs for admin staff, and everybody said it was Indeed. We also checked out LinkedIn and found a lot of overlap with that, as well as other job sites. And we found very few postings on Indeed for Quebec positions, and a lot of them were in the job bank, which is jobbank.gc.ca. So we ended up going with these 2 websites for our search to reduce duplication, but also ensure fair coverage across the provinces and territories. And so in each of these websites, we did a province-specific search for both all terms related to administrative work, primary care, and then also for management and leadership positions. And to be included, a posting had to be in primary care, for administrative or managerial duties, and it had to be completely separate from clinical roles. So if there's a medical director position that required a certain percentage of time to be in practice, we excluded that. And so we screened, the first level screening was just using the job title and the organization name. So we were very inclusive, especially for the organization name. If we weren't sure, we included it. And full job postings were screened independently and in duplicate. So we found, the search was done in December. We found 94 job postings across the provinces listed and territories listed. If they're not listed, that's because we weren't able to pull any relevant postings at that time. We were pleased to see 16 postings for managerial positions because we really felt like these might not be posted as much. So we were happy to see some of that, and not surprisingly, most postings came from Ontario and British Columbia, but we did have representation across several provinces. So the rest of my results for this project are going to be specific to the administrative roles, in part because we're still analyzing the data and because there's limited time. First, I'm going to talk to you about roles and responsibilities. And if you run a clinic, this shouldn't be surprising for you at all. But we found categories across administrative tasks and clerical tasks. So really not surprising: reception, registration, telephone, etc. But I do have some illustrative quotes here that I think might be a little bit of an outlier or a little bit surprising to some people. So this one was preparing correspondence between physicians and patients, including patient letters, medication prescription information, completing forms, including disability claims, nutritional meal supplements, etc. And that was for a medical office assistant. Clinical duties as well, so exam prep, as well as routine measurements and vital signs, sterilization of spaces and equipment, and also taking patient histories. So here, we were surprised to see that it involved attending sensitive examination procedures and treatments, conducting eye exams and urinalysis. So that was for an MOA in BC. And another position in Ontario for a clinic float that was mostly administrative included assisting physicians during patient examinations. Human resources tasks were also common, so onboarding new staff, maintaining training materials, and managing human resources processes. We were surprised to see that it also included providing training and education in the EMR, which is a little bit more technical. And under other, we have inventory management, and we're surprised to see technical support for virtual care, as well as fairly advanced communications. So here, a medical secretary job description included creating surveys, collecting program data, generating reports, and providing those to the leadership team. And another position, assisting in preparing, editing, and distributing internal and external communications on behalf of the leadership team. So fairly advanced skills. So to do these roles, we found that 20% didn't specify, so that they likely don't have a minimum amount of time, with 2.5% specifying a year, less than a year. But the chunk of the postings required 1 to 2 years of related recent experience, and 18% requiring 3 to 5 years of related recent experience. For qualifications, basically across the board, everyone specified a high school degree with some kind of MOA, certificate, diploma, or course. Most wanted primary care specific knowledge, including EMR systems, medical terms, experience with billing and fee codes, and ability to perform very basic medical tests and accurately record results. Not surprising, relationship skills were very prominent, being a team player, being professional, customer service, but also cultural sensitivity and community awareness, and sometimes experience working with certain populations, especially Indigenous populations, for those specific settings. We also found general skills, such as a minimum typing speed, ability to multitask, prioritize problem solve in a high pressure environment, as well as independence, initiative, keeping confidentiality, and following instructions, with some postings requiring specific physical abilities for the job, driver's license, etc. And with this very well-rounded position where people have to multitask and have a variety of skills, we were quite frankly surprised to see a minimum starting salary of around on average, $23.68, meaning that some started much lower, around $20, and an average maximum salary of $26.67 an hour. So on average, this was $48,000 annually. And this was common annualized salary. And when we looked at clinics in downtown Toronto, downtown Vancouver, where cost of living is quite astronomical, making these positions quite close to the poverty line. Only 50% were full-time, with 27% being part-time or casual. Really 26% were unionized position, which we felt was pretty impressive. And only 33% noted offering paid vacation time, but 50% did offer benefits. So to conclude for this bonus project, we feel that in a context where primary care clinicians are burning out, administrative workloads are increasing, and new physicians are not interested in office-based care, we're left sort of scratching our head and wondering, are we investing enough in our administrative workforce? And we feel the answer to that is no. So we're interested in taking that really to policymakers who are pushing more and more and more onto our primary care clinics to know that we do need to better support that administrative infrastructure. Sorry, my cat, I don't know if you can hear that, is here meowing at me. And last but not least is a current study that we've recently gotten underway, funded by CIHR, which we affectionately call the Pracman study, and put that into a logo. And that stands for Primary Care Practice Management. And so it's really addressing the fact that little attention has been paid to how well primary care clinics are managed. When we talk about practice management, that's administration and management of clinics or community health centers. That includes operations such as infrastructure, staffing, information management, finance, and quality and safety. So we have 4 ambitious research questions. Now, the project was cut from 4 years to 3 years by CIHR, including a 25% cut to the budget as a result. So we'll see what we can get done. But the first thing we wanted to know is what resources are available to support practice management. And for that, we're doing an environmental scan. Then we want to know what are the current approaches to practice management and how do these vary by practice and payment model. And for that, we're doing a survey in 3 provinces. We'll do follow-up interviews to the survey to understand the experiences of people managing clinics, what they perceive are best practices and barriers. And then lastly, if we can squeeze it in, we'll do some case studies of team-based primary care practices to really see how practice management principles are implemented. And to do this, we've blended the literatures from the management literature and research and primary care research. So we're taking Henry Fayol's foundational management theory that stipulates that successful businesses of any size must be managed according to 4 functions, which is planning, organizing, leading, and controlling. And we've merged that into a table with the Engels and colleagues 2005 paper that identified 5 domains of primary care practice management, which includes infrastructure, staff, information, finance, and quality and safety. Now, we used our knowledge and literature to kind of populate this table, but basically as we go through the 4 phases of the study, we're looking to fill this in with more empirical evidence. So we're currently waiting for the final REB approvals to launch our survey, surveying leaders, whether those are staff or clinicians responsible for running a primary care clinic in BC, Ontario, and Nova Scotia. We're collecting data across that table, really. And some example questions are, who is responsible for EMR maintenance support and troubleshooting, as well as does your clinic or center have, and then one of the items on the list is standardized job descriptions for non-clinical staff roles. So I'm going to conclude with some questions for you to launch our discussion. And I'm curious what resources, websites, or organizations you might recommend we search for in our environmental scan on supports for management. And what strategies might we use to reach clinic owners, managers, leaders to complete our survey? And that's it for me. I didn't look into the chat, so I don't know if there's any questions there, but I'm happy to take your questions and also your answers to my questions.
Thank you very much, Agnes. That's great. Sort of a great overview of these three projects, very interconnected. I certainly see that, I mean, to me, I mean, I see this and I think workflows are sort of connected to all three, and particularly the admin. I'm wondering too, not only, in terms of, are we valuing, but, are the structures of these roles correct, right? So anyways, you've put some very good questions for folks, and people may have some other thoughts. Claire's been very active in the chat, so you may choose to address maybe one of those questions, or if others have questions, please go ahead. We've got a few minutes here. Arun, go ahead.
Thanks, Doug, and thank you, Agnes. Great presentation. And I'm going to build off of some of what Claire's been asking in the chat. I think, Agnes, maybe this is a larger conversation about AI and how it's going to affect the administrative component of what's happening in the clinics. So when you go back to one of your questions that you asked, what's the environmental scan? Where should we be looking? I think maybe also getting an inventory of what is happening with the AI products is an important piece in terms of knowing that this is an area that a lot of industry partners are targeting. So that would be one component. The second thing I would sort of encourage is that as you're looking at the work that you have done, I think there's automatically some really interesting collaborations with a number of people on our call today. Who are doing work around trying to take off some of that administrative load from the clinicians. So how does the roles and the tasks that you've identified in the training pieces, how does that interface with some of the work that people are doing? Like, for example, I think one of the projects that Sharon Johnson's working on, a project that Camilla Premji is working on would be, I think, great opportunities to collaborate there. And even from, I'll speak from my work, we're doing wrapping up a study that's looking at what are the AI tools primary care clinicians are looking for. And they've obviously identified a number of tools in the administrative domain. And so there may be some nice interface between the work that you've done that describes the roles and then talks about the tools that are being produced. And the last piece I'll turn maybe your attention to is as you're thinking about where to disseminate this information, I wonder if dissemination of your work isn't just to government and policymakers, but it's also to industry, because I think industry is very keen to invest money and to go in this direction, because this is one of the few places where AI is yielding potentially revenue generating businesses, a significant revenue generating opportunities. And so if they have an idea, if industry can have a better sense around what are the roles, what are the role tasks defined in a very clear way, in the way that you have, that might enable more optimized development of tools and might sort of support sort of building that ecosystem of tools. And I think that's important because, quite honestly, if you look at where we are from a public sector side, really, what's the likelihood they're going to move with speed to actually try to compensate or bring in structures or funding for administrative support? More likely than not, this is going to be an industry-led response, and clinicians are going to sort of really look to that as probably where we're going to go with speed. So, a lot there, but I'll pause.
That's great. Thank you so much. I wrote all of that down, and I have to say, I didn't think about the AI component. And, as we spoke about yesterday, it moves so fast. Like, how do you even capture that and disseminate it, publish it? Like, it sounds like a perfect student project. But by the time they're done, like, that information is no longer relevant. So it is a challenge. But yes, no, I've written that down. And thank you, Claire, as well, for bringing up the AI. And I love the suggestion about looking at how much funding is going to admin support across provinces. So I wrote that one down too. That's great. Sharon?
I would just add, I absolutely agree with Arun, but the model of primary care is they're independent shops. They've never been supported. There's no IT factory in the basement telling them how to, connect their fax to somebody else's and checking their permissions, right? It's all, and nobody has any expertise in this. There's nobody who goes into primary care who has trained. There are a few, but very few who have trained in sort of optimizing systems.
Yes.
The AI thing is real. Last month, we took our admin team from our clinics and gave them an AI training course, and they said it was life-changing. They understood how they could use tools in the EMR that were already there. They stopped being scared. They understood the privacy requirements, et cetera. So it was just, like a 4-hour training, but that's pretty expensive because this is all paid for out of the smaller clinics. But there were tools out there that they weren't using. There's also an admin training course offered in the fall at Montfort for health admin. I don't think they've ever targeted primary care. It was apparently very well received, and it was largely sort of for hospital or university admin personnel who were learning new tools. And the feedback I got was that it was amazing. It never occurred to anybody, I think, to sort of reach out. Would this be something to make for primary care admin teams? We just don't think that way. They're little shops and they sort of do it on their own and figure it out without necessarily sharing information across settings.
Yeah, thank you so much, Sharon. And what you said at the very beginning, the fact that everyone's doing it on their own, they have no support and no training, is exactly why I'm nerding out so much on this. I'm coming from, like, I have a BCom and I'm in a management school as a health services researcher. Like, this is such a problem that keeps me up at night, and that's why I want to bring attention to it. So, like, you're on point. I'm so in agreement with you, and I feel like we need to talk about it more. Claire?
What mini comment to echo like the speed, that like the differential speed between research and the AI company arriving, and also like, I don't want to use AI yet. Like I'm like, in clinical work, like I'm afraid, I'm a geriatrician. I don't want to start to explain to patients, like, like I'm going to record what you say, and actually that's going to go somewhere where there could be leakage. Like it seems to be too much to me. But actually, there was a ground round last week in our department that said, like, the title was AI, like, a physician that don't use AI will be replaced by physician that use it. And, like, for example, our government says that I need to have seen all my consults in the morning within 2 hours, knowing that it takes me 2 hours to see one, and that sometimes in the morning I have 5. So, of course I cannot, but, these government targets, at some point, I will be like people will say, no, Claire, you cannot continue typing your notes. There will be like this pressure that, no, I need to use AI. And I heard from colleagues in the US that actually they work in a private system, of course, and AI robots are checking the quality of their notes. And so if you write an authentic note, the AI robots find that suboptimal. So actually, if you want to be like to the standards of AI robots, you need to have all your notes written by AI. And so the pressure is so strong and came so fast, actually. So yes, yes, we need to have a lot of students that do summer project on that.
I agree. Thanks, Claire.
Well, great conversation, everybody. This is terrific. And by all means, continue questions, comments in the chat. With that, we'll move to our second presentation. So thank you very much, Agnes. And next over to Sathya and Claire.
Thank you so much, Sathya. So we're going to speak about equity in care of persons with dementia, from measurement to action, and why equity? Perhaps because equity is attacked from everywhere. And so it's more than ever important like to speak about it. Next slide, Sathya. So here I thought, what about we do something that was not planned? And so with the permission of indigenous scholar in our department, I think that instead of reading again a land acknowledgement, I would show you like persons with from who are indigenous are more at risk of dementia, more at risk of inequity in their access to care. And actually, we have two Canadian teams who are working on these topics. It's not the topic of our today's presentation, but I wanted to showcase them. So the Indigenous Connective Health Program, Pamela Roach and Jennifer Walker, you might know some them. And perhaps, so there is a lot of guidance on how to do a responsible research with Indigenous communities, a lot of work. And one thing that might interest you as clinicians might be to be aware that there is a Canadian Indigenous cognitive assessment that's been validated and that you could use in your practice. So coming back to what we said, we would do. Are you sharing? Yes. Huh? You saw my screen in the meantime? Okay. So thank you so much. So coming back to our presentation, so why are we interested in equity in dementia care? So first, because persons with dementia are at disproportionate risk of inequities. First, because the dementia risk factors are associated strongly with lower socioeconomic status and with many axes of disadvantages. Next slide. So you might have seen this graph, the Lancet Commission. So here you have all the risk factors for dementia, and actually like so many of them are actually associated with lower socioeconomic status, like education, tobacco consumption, alcohol consumption, obesity, cardiovascular health, and diseases. So for sure, like the dementia risk is inherently more at risk in more disadvantaged population. And also, like persons with dementia have a very complex trajectory. So starting from the diagnosis, up to 2/3 of them are not diagnosed. So starts bad, diagnosis of dementia is a bit more complex to do than diabetes diagnosis. And a lot of nihilism, both in the side of healthcare professional, like why diagnose when we don't have an effective treatment, and a lot of taboo, stigma, and lack of knowledge in the population around the signs of what is dementia, what is normal aging. And then the trajectory is complex. Like you need several types of healthcare professionals throughout your journey. And when you have a problem, it's not easy as other diseases where you decompensate all the time the same way and the treatment is all the time the same. And then also persons with dementia have difficulties being heard. So like as the disease progresses, it's harder to be an advocate for one's health and you rely more and more on your caregiver. And yes, so all of that is like the perfect combo to experience inequities in both getting a diagnosis and then getting the services you need when you need them. So, however, there were very limited data on it in Quebec, where I'm situated, and in Canada. And actually, in the Canadian dementia strategy, although they do mention inequities, some populations that are more at risk of dementia, there was not yet one of their objectives as reducing inequities. And we know that when you implement a population-wide intervention and you don't focus on the people who are more disadvantaged, you're actually at risk of exacerbating inequities. So because people who are more advantaged have more resources, more literacy, more money, they're going to take up the innovation, take up the new intervention faster. And people who are more disadvantaged are going to take it up slower. And so that's going actually to increase inequities. So we thought, let's first measure. And so I'm going to present you our first results on inequities. So what we did, that was in Quebec. We looked at health administrative databases from 20,000 to 2017. We included around 200,000 community dwelling persons with incident dementia in Quebec. And we looked across 27 outcomes of care, health services use, mortality during the year of diagnosis. And we stratified these outcomes on ecological variable, like the socioeconomic status of the census dissemination area around you. So the 500 to 700 people that live in your neighborhood, really next to you, what about their education, their employment, their income? And then we did graphical assessments of the curves I'm going to show you. So here you see all the graphs are structured the same. So you have the time in the x-axis, and in the y-axis you have the age standardized rates, and the light blue shows the outcome during the year of sorry, I cannot double task. I saw Howard Bergman comment. Howard Bergman commented on the fact that actually the Quebec Alzheimer's plan had one of its 6 pillars as being reducing inequities. And that's one of the great success of our research program, because we discussed a lot around equities. We did measure inequities. And then Howard Bergman had to write the new Alzheimer's policy in Quebec. And he included one of the axes as reducing inequities. So that's a impromptu way of showing you the impact of our research in the middle of presenting it. Sorry for the going everywhere. So yes, so the graphs, so time in x-axis, age standardized rate in y-axis, and then lowest socioeconomic status in light blue, dark blue is highest socioeconomic status of the neighborhood of residence. And then you see that over the years, actually the curves are like not crossing each other. It's quite consistent that actually if you live in a neighborhood where the most deprived neighborhood, you're more at risk during the year of diagnosis to go to the emergency department at least once, have at least one hospitalization, have potentially inappropriate medication like benzodiazepine and antipsychotics. Sathya, right. But also like to be admitted to long-term care or die during the year of diagnosis. So all of these, graphs could tell you, okay, the people living in lower socioeconomic status neighborhood actually were more severe. Like they had more behavioral and psychological symptoms of dementia. They needed to go to the emergency. So they were sicker. So you think, okay, is it inequities? Like if they are sicker, they go more to the emergency, they go more to the hospital, they need more potentially inappropriate medication that are here for their behavioral symptoms. They were closer to death, so they are sicker. But at the same time, they see less cognition specialists. Strange. So that's where we're like, these differences actually might be inequities. So then, Sathya, and then some indicators did not have differences across socioeconomic status of the neighborhood, which is a bit reassuring in a universal healthcare system that's supposed to give access to everything to everyone, not depending on their wealth, income, and resources. So visits to primary care physician was not influenced, and having a dementia-specific medication was not influenced. So then we looked at, with the same, and Agnes, you might call that a pop-up project. So with the same cohorts, like we had these people, we analyzed their health services use. Then we thought, what about we analyze just who we have in the cohort? And actually that might be a second article, which might be cool. So actually what we see here is that these are all the people I presented you the result from just before. And you can see like where are the incident cases of dementia across deprivation of their neighborhood of residence. And actually what we see is that there is a bit of a difference, like there is a bit more people diagnosed in more deprived neighborhoods, 22% versus 18% in less deprived neighborhood. But these differences do not reach what we should find when we look at how socioeconomic status is a predictor of having an incident dementia. Like the difference we find here show that we are actually missing many cases in the most deprived neighborhood. And actually like up to half of the cases that we diagnose, we are actually missing. So we suspect a lot of underdiagnosis. And so, as I was discussing, like we found all these socioeconomic differences in most indicator actually, and these differences may signal inequities. And I think I'm done. Sathya, your turn.
All right, thank you, Claire. So the next part of the presentation focuses more on, how this kind of measurement has inspired more, I guess, participatory action type research from our group. And I'll focus mainly on work we've done in terms of co-designing policy recommendations with community organization. And if there's time, I'll also make mention of some work we're doing on accessing specialists, making access to specialist advice more equitable through eConsult. So coming back to what was just mentioned briefly earlier, we're focusing on Quebec, partly because, I think Quebec was a bit ahead of the game, or maybe very much ahead of the game compared to other provinces. In 2009, they developed the Quebec Alzheimer Plan, led by Dr. Howard Bergman, and then in 2025, as was mentioned previously, the Quebec Ministerial Policy on Alzheimer's Disease, and that policy was released in February 2025. And is composed of 5 axes, but we want to focus here today on the third axis, which is taking into account diversity of people and their social determinants to reduce inequities. And one of the interesting things is that the next stage of this, so the policy that was released is to provide guidance for the development of a 5-year operational government action plan. So that's where, we're hoping that we can produce data that will inform directly the action plan. As Claire mentioned earlier, actions can sometimes increase inequities. So we want to make sure that we're addressing those as much as we can. Also, just to contextualize, most of us here are in Ontario, and there was a bill, Bill 121 here in Ontario to enact the Improving Dementia Care in Ontario Act that was released in 2024, and does also so in that bill, basically the recommendation is to create a provincial framework, and one of the components of that framework is to identify measures to facilitate equitable access to dementia care. So this is on the radar in Ontario as well. But I want to come back to the work that we've done in Quebec quite recently in terms of co-designing a policy brief to address barriers faced by equity-seeking community to develop recommendations that would address those inequities. So to do this, we used deliberative dialogue, and basically, so here's a bit of the timeline. So the policy was released in February 2025. In May 2025, we had conversations with the Alzheimer's Society of Quebec as well as the Canadian organization, and we partnered with, or we pursued partnership that we had already established with ACDPN, which is the African Canadian Development and Prevention Network, based in Montreal. And I'll just mention that ACDPN is essentially, it says Canadian, but it really is an organization that serves the community in Montreal, the Black English-speaking community. And I want to emphasize that these are then minoritized on at least 2 dimensions. dimensions, right? So there's the racialization, and just a reminder that being English speaking makes you a linguistic minority in Quebec. So in June of 2025, we held our first deliberative dialogue where we engaged with 11 participants from the community, and essentially started by sharing an infographic showing them some of the modifiable risk factors for dementia and how inequities may arise, what the care pathway would be for dementia care, and then discussed with them, their experiences with accessing care. In July 2025, we shared those findings. We conducted a thematic analysis of what the information they shared, and discussed these with the Alzheimer's Society, and got input from them in terms of what recommendations could be developed to address some of the issues that the community had spoken about. We met with them again in August of 2025 to synthesize and generate recommendations that they thought were really the priorities. And here's just an infographic that we started with, again, kind of highlighting some of the stories and experiences they shared to help formulate the recommendations that might address these concerns. And then, so we are now in the process of, we've, put together the policy brief. We're going back to the community to finalize the recommendations with the intention of sharing this with the Ministry of Health and Social Services in the spring of 2026. So just, kind of over 2 lunches with this community of 11 community members. So it was the same group that came both times. We came up with 6 recommendations, so that will be disseminated in the form of a policy brief and a publication. And, just to emphasize in terms of the approach, we really did build on a long-term relationship that had been established with an organization that was already kind of quite well structured and focused on this kind of work, but it did require quite a bit of back and forth and engagement. But there is certainly interest in future collaboration to explore further, how we can work together to support better access to care. I'll switch gears a little bit here in terms of just talking about other types of, sort of the action-oriented work we're doing. This one focusing on also work across Ontario and Quebec, looking at how an existing service, eConsult, that's been implemented across both provinces might be either improving or perhaps not improving equity and access for people with living with dementia in the province in terms of accessing specialist care. So very quickly, if you're not familiar, eConsult is a service that allows a primary care provider to communicate with a specialist if they have a concern that arises from an encounter with a patient. They can contact a number of different specialty groups and input their question, and usually will receive a response within a day or 2. And this has been evaluated quite widely across multiple patient populations. So we're focusing now on the dementia patient population and how this might serve them. But we're also, our interest here is in using the provincial data and looking at who does get access to an eConsult and who doesn't. And we're doing that with health administrative data, but also through qualitative work, interviewing providers as well as people with lived experience from underserved communities. So that's ongoing work, again, looking at how the system might or might not be meeting the needs underserved communities. And then just very quickly, I'll end with this network that was recently funded by CIHR that Claire and I are leading. So expanding on some of the work that we've just described, using health administrative data to describe inequities, and then engaging with communities to inform priorities for practice and policy changes. We're currently in the first phase where we're looking at cataloging databases that contain information that would allow us to really document, to study this. So looking at where data has been collected around racialization, language, and other dimensions that we would want to study in terms of access to dementia care. And we're doing this with across 6 provinces in partnership with a number of a very large team of researchers, but also partner organizations that are informing the approaches. And here are some of the methods we'll use. And some of these we did present already, so I won't spend too much more time. Just want to thank, recognize our funders and Dr. Howard Bergman and Isabel Vidal, who have been mentors and leaders in this work, as well as our trainees and research assistants. Thank you.
Well, thank you both, Sathya and Claire. Great overview of the work that you're doing. We've got about 5 minutes for questions. I guess hand it over to you, Dr. Bergman.
Hi, I just want to salute this excellent work by Sathya and Claire. And just to say, I was the lead author of the Quebec Alzheimer policy, the first ministerial policy, 2025. And as Sathya mentioned, equity was a central point of this policy. Just 2 quick things is the notion of equity doesn't simply mean care around care. It's also around the risk of developing the disease. There's more and more evidence that low economic status, low education status, and living in vulnerable neighborhoods increase your risk. The second point I want to make is when we talk about care, we generally talk about access to care, etc. But I want to also indicate the importance of brain health and prevention in this notion of equity. So if we develop a generic program of prevention, brain health and prevention, who's going to take it up? You know the answer to that question. So that's why Mary Tinetti said, one size fits all leads to health and equity. I think that we have enough data on the social determinants. We have enough data. Now, what we need is the data and the intervention. That's why I really like what Sathya was saying about the real challenge is how do we do this? How do we develop interventions for prevention, promotion, care that target, that adapt to, culturally safe, etc., to the population that really need it. And that's the real challenge at this point.
Yeah, thank you, Howard. And I mean, we didn't go through the recommendations because we're still finalizing them with the community, but one of them did mention, the kind of education and health promotion messages have to be tailored, have to be culturally appropriate. And that is kind of some of the work we are doing in terms of co-designing knowledge dissemination tools that are specific to communities.
And just to add an answer, I agree with you, Howard. Like everything's known, like social determinants of health have been long studied and long said, and and our patient partner also, like they are like, oh, researcher, like stop measuring, like act now. We want to act. We know there are inequities. However, very interestingly, when I first presented the study I just showed you to the Quebec Research Network on Aging, the 2 questions I got were, that's not possible. We have a universal healthcare system. I'm a professor of epidemiology. There must be a bias. So that was a couple of years ago. It's just that interesting how we, I don't know, like how we mask our eyes, and we are all the time saying, oh, we have the Canadian Health Act and everything universal, comprehensive, but this is not the case. And anyway, I truly agree with you. And sometimes I'm like, oh,
Any other comments? Howard, is that a residual hand or is this another comment?
It's an old hand. It doesn't seem to be going
Okay.
down.
No worries.
Perhaps another thing I could mention, some of you reach out to us in the chat. Actually, we have a patient advisory group, but we also have clinicians advisory group. So if you're interested by our research, if you're interested by how we can make e-consult a law for more equitable care, if you're interested in like how primary care can get insight advice from specialty care, and what are, like, we have a couple of projects on how we can support family physician in the work of diagnosing dementia, getting specialist advice. And what we do, like as a mirror of what we do with patient partners, we do it with clinicians. So we want all our research to be informed by clinicians, to be sure that we are not like, somewhere in the air with researcher questions. Like, we want to answer your questions, and we want to be really grounded in problems that happen on the ground. So if you're interested to join our clinician advisor group, more than happy to welcome you.
Maybe Claire and Sathya put your emails in the chat. That would be great. And actually, on that note, we are at time. Please do fill in the session evaluations that are posted in the chat. And a big thank you, Sathya, Claire, Agnes, fabulous presentations. And thank you all for joining today for Grand Rounds. We look forward to seeing you next month.